I would like to start this talk by acknowledging the Turubal and Yagara people, the traditional owners of the land on which I am speaking this morning. I would like to pay my respects to their elders past, present and emerging. Today, I will be speaking on how we can apply a systems-based approach to prevent adverse events. I'm going to start today's session with an introduction to one of the case studies that we are going to explore. Mrs. S was a young mother-to-be in Perth. She lapsed into a coma after being given 100 milligrams of morphine during labor instead of the standard maximum routine dose of 10 milligrams. After lapsing into a coma, Mrs. S was rushed into the ICU. While she was able to come out of the coma, unfortunately her baby died as a result. Up until this medical error, Mrs. S was having an uncomplicated pregnancy. The hospital in Perth concluded their investigation by stating that a human error occurred. One midwife was suspended, while another staff member handed in their resignation. As we go through the rest of this session, can you have a think about what should have happened in this case? Does suspending the midwife make sure that this type of medical error doesn't reoccur? How can we manage this adverse event using a systems-based approach? Today's session will provide an understanding of systems-based approaches to managing patient and staff safety risk through retrospective and prospective analysis. I will share with you the tools available for analysis of adverse events and potential hazards, as well as show how these tools can be put into practice with the help of case studies. I will also look at how the CAPA framework and the hierarchy of controls can be used for successful implementation. Adverse events provide clinical and management teams with important information on what needs to change to make things better. On an average day in Australia, well-trained and dedicated healthcare providers care for close to 30,000 new inpatient admissions. For the overwhelming majority of these patients, the care is delivered safely and effectively. It is important to acknowledge, however, that despite the best intentions of healthcare providers, doctors, nurses, midwives, and allied health, things occasionally do go wrong. Similar to the case of Mrs. S, it is estimated that 1 in 20 patients experience an adverse event while in an Australian hospital. As shown by the graph on the right, adverse events are also more likely to occur in surgical admissions than in non-surgical admissions. Adverse events cause physical and emotional harm to patients, their families, and to hospital staff involved in the event. This also generates a significant social and financial burden. I hope by the end of this session, you will look at adverse events differently. You will see them as real opportunities to improve healthcare systems, and you will have the tools to do this. Let's look at how a systems-based approach can be used as a way to effectively and proactively manage adverse events. We start by defining what we are looking at. A system is a set of policies, processes, and procedures designed around people and equipment required for planning and execution of core functions of an organization. Historically, when an adverse event occurred, the tendency was to look for the most obvious explanation of what and why it happened. In most cases, individual human error was identified as the cause, primarily because it was easy to identify and appeared to be easy to fix. The outcome of such an analysis may have included additional training, disciplinary actions, as in the case of Mrs. S, or an expectation of increased personal vigilance. It became apparent, especially within industries outside of healthcare, that it is important to have a systems approach to incident management and review what underlying factors within a system contributes to human behavior. So why use a systems-based approach? A systems-based approach has some inherent advantages to the historical human error-based approach. It acknowledges facts of life, that is, universal nature of humans to falter, and the inevitability of error and hazards. Errors and hazards will always be present. By acknowledging this, we can design a structured way to review and improve the systems in place to reduce the likelihood of these errors and hazards, and more importantly, the consequences. In order to prevent adverse events, there are two key perspectives that must be addressed by facilities. First, a retrospective view, which is after an adverse event has occurred in your healthcare facility. Second, a prospective view, which is before an adverse event has occurred, but you have identified a potential adverse event. Both retrospective and prospective analysis offer opportunities to learn and improve current systems. We will start with a more detailed look at how the retrospective analysis can be done so that we can manage adverse events using a systematic approach. We will start with a more detailed look at how the retrospective analysis can be conducted. Retrospective analysis uses two different tools: root cause analysis as the analysis tool, corrective and preventive action framework, or commonly known as the CAPA framework, is used as the tool for implementing solutions to address the adverse event. What is a root cause? Root cause is defined as the original source of the problem and usually is not obvious when the problem occurs. What we often see when a problem or an adverse event occurs is the symptoms of the problem within the system, represented by the leaves. Root cause analysis helps to identify why repetitive human errors or equipment failures are associated with specific processes which lead to subpar performances and adverse events. Within industries outside of healthcare, human errors are considered symptoms of the problem. Healthcare is also slowly adopting this process, with patient safety experts now strongly advocating a way of thinking that views human errors as symptoms of broader issues within a poorly designed system. These are some tools used for conducting root cause analysis. Today, we will be going into detail in how to use the top two tools in yellow, 5 whys and the Ishikawa or fishbone diagram. We will also go through our first patient and staff case studies to put these tools to practice. As the name suggests, using the 5 whys approach means repeatedly asking the question why, so you can peel away the layers of symptoms to lead to the root cause of the problem. It is helpful in tracing a chain of events, starting with adverse event and working backwards. Although this technique is called 5 whys, you may find that you will need to ask the question fewer or more times than 5 before you find the root cause related to a problem. 5 is used to remind you to dig deeper into the problem and get past the surface explanation. Moving on to fishbone or Ishikawa diagram, it is used to graphically identify and organize all the contributing root causes of a problem. The fishbone approach helps focus problem solving and reduce subjective decision making. It is particularly useful when the analysis is done in a group setting, such as in M&M meetings. It works in situations where there is very little quantitative data available for analysis. It is also great when there is a need to display and explore many possible causes of a specific problem. How do we use fishbone or Ishikawa diagram? You start on the right with the effect or the problem. It is specifically designed in this orientation of right to left so that from early on you recognize that the effect or problem you see on the surface has an underlying cause or causes. Once you have placed the problem statement at the head of the fish, the rest of the fishbone diagram then consists of one line drawn across the page and several lines or bones coming out vertically from the main line. You label the bones coming out by identifying what are the different contributing factors. Once the bones are labeled, begin brainstorming possible causes and attach them to the branches. For each cause identified, continue to ask, why does that happen? This will help you to get to the true drivers of the problem. Once you have done the root cause analysis and identified the causes that resulted in an adverse event, the next step is to recognize and implement solutions. To do this, we use the corrective and preventive action framework. It is also really important at this stage to distinguish the differences between corrective and preventive actions. Correction actions eliminate the immediate problem. It doesn't eliminate the issue permanently, but allow a process or work to continue. If we look at a simple example of where there's a water leak from a tap, the correction action is to mop up the water and add a bucket under the tap so that it removes the hazard and allows the process to continue safely. So for people to use the tap without flooding the room. Corrective actions eliminate the cause of the problem or adverse event and prevents repetition. So with the leaking tap, one should investigate the sink, drain and the water supply system. This is the root cause analysis. Let's say we identify that there is a broken washer in the tap causing the leak. Replacing the washer is the corrective action. Preventive actions prevent potential occurrences of similar issues. Preventive actions try to address the issue before they happen. So in the case of the sink, we can develop a maintenance schedule to review the water supply system in all sinks. This maintenance schedule should include a checklist that addresses the water supply system, including the washers, and provide training to relevant personnel. This distinction between correction, corrective, and preventive actions is critical for successful follow-up plan. It is always important to ensure that the correction, corrective, and preventive actions addresses all the root causes. When we look at the CAPA framework for implementing solutions for a root cause, it often requires changes to existing systems or processes, or implementation of new systems or processes. So it is important to recognize that this requires commitment in terms of resources and time. Finally, the effectiveness of CAPA should always be audited. This is to ensure that the actions that have been taken to fix the problem and prevent future problems are actually effective. Some common examples of effectiveness checks are listed on the slide. Let's now go through some case studies to see how we can implement retrospective analysis for patient and staff safety incidents. We are starting off with the patient safety case that I mentioned before, where an expectant mother was given the wrong dose of morphine. This particular case study hits close to home for me because similar to the patient in the case study, I was also pregnant with my first baby at the time. The hospital in Perth concluded their investigation with the following outcome that I have quoted here. It was a tragic occurrence caused by human error. Yes, a human error did occur, but is this the true root cause? I think it is clear to you and I, human error in this case is a symptom of broader issues within a poorly designed system. So let's see if the outcomes of the investigation differs if we take a systems-based approach. We quickly realized there are a number of contributing systems or processes, so we moved on to a fishbone diagram for this case study. As the first step, we defined the problem. Then we used brainstorming exercise to identify the bones of the fishbone diagram. The different systems or processes involved are the prescribing system, the dispensing system, the drug administering process, and the patient monitoring process. Let's start with the prescribing system. The patient was wrongly prescribed 100 milligrams of morphine instead of the 10 milligrams. When this happened, the electronic prescribing system didn't flag that this is 10 times the standard dose. The prescription was then dispensed. The healthcare provider dispensing the prescription was not alerted by the system that this is 10 times the standard dose per patient. The double check carried out prior to administering the drug to the patient didn't recognize this is 10 times the dose as well. Why? The double check relies on experience of the person who's doing the check. It is likely there were no drug dosage charts or visual aids in the maternity ward to assist with the process. Finally, the patient monitoring has failed as well. It was only the next morning that the care team identified Mrs. S was in a coma. Her husband thought she was sleeping. Mrs. S's deteriorating conditions were missed during routine inspections till next morning. It is likely the routine respiratory rate measures were not carried out as the midwife was too busy with other patients. What she observed when she saw the patient sleeping is what she is expected to see. Why did this happen? likely due to poor staffing ratios. It has recently been reported that this particular hospital did in fact have poor staffing ratios, leading to number of issues. Based on this analysis, we can identify 4 root causes which contributed to this error, leading to the adverse event. 1. Prescribing system didn't flag that this is 10 times the standard adult dose. 2. Dispensing system didn't flag that this is a 10 times standard dose and 10 ampules, not the expected single ampule. 3. The double check relies on experience. There was also no drug dosage chart or visual cue in the ward. 4. Poor staffing ratios. Now think about the report from the hospital investigation. A tragic occurrence caused by human error versus the causes identified by this systems-based approach. You can see that an opportunity to learn and improve was missed by focusing on individual behavior by the hospital rather than a systems-based approach. Nothing in the hospital's approach prevents this from happening in the future. Let's now look at what correction, corrective, and preventive actions can be taken to address these root causes we have identified. For root causes 1 and 2, potential corrective actions include incorporating alerts in the electronic prescribing and dispensing systems when opioid dosage is over standard limit, or even to have a standard dosage per patient included as line items in the system. Once the system upgrades are done, it is important to provide training on these upgrades to relevant staff. There are also potential preventive actions that can be taken to prevent potential occurrences of similar incidents. For example, comparing and contrasting processes in other wards when it comes to safe opioid use or other similar drug categories. Compare birthing suites to ED to the theatre. For root causes 3 and 4, correction actions are the same as before. As a corrective action for root cause 3, we can add an opioid max dosage chart or simple signage at prep stations in maternity wards which states no more than 1 ampule per patient is a good rule of thumb, instead of relying only on the experience of the relevant staff members. As with before, any such changes should be complemented with necessary training. Corrective action for root cause 4 is to review staffing ratios in the maternity ward. The preventative actions for both root causes include compare and contrast processes in other wards when it comes to opioids or other similar drug categories, and to investigate whether staffing ratios in these wards are optimal. Remember, this work is not useful if we do not verify the effectiveness of the correction and preventive actions taken. To measure the effectiveness of these CAPA actions, we can aim for absence of similar adverse events or minimum threshold levels for similar incidents as an effectiveness audit. We can also spot audit to ensure the processes in place are being adhered to. This is not to identify whether individuals are faltering or not adhering to processes, but rather to see whether the new processes are simple and fit within standard behavior and work processes of teams. The effectiveness check can be done after a period of 6 months or 1 year, depending on the frequency of such dose administrations. Now let's look at how we can use the retrospective analysis for a staff safety case study. A 24-year-old female nurse had a penetrating injury to her right wrist while she was disconnecting the blade from its holder. She was holding the scalpel handle by her left hand, trying to disconnect it by an artery forceps with the right hand when the blade slipped and penetrated the medial aspect of her right wrist. This resulted in severe pain and pulsatile bleeding. Immediately under local anesthesia, the artery was ligated. Scalpels are second only to suture needles for a likelihood of a sharp injury in the operating theatre. We conducted a 5-eye root cause analysis on this case study. Why did this injury occur? First, the nurse was holding the scalpel handle in the left hand and the artery forceps in right hand. This was a two-handed process. Why? Scalpel blade slipped from the grip of the artery forceps, injuring the nurse. Why did the blade slip? Artery forceps are not designed to remove scalpel blades from scalpel handles safely, resulting in user errors. Why were artery forceps used? It is likely that safety devices designed specifically for removal of scalpel blades to prevent such user errors were not provided. It is important to note here that it would have been very easy to stop the analysis at Y2 and focus further CAPA activities on errors associated with the use of artery forceps by that particular staff member, such as training. Again, this would mean stopping root cause analysis prematurely and leading to ineffective CAPA activities. We need to ask ourselves whether providing additional training to that staff member will prevent similar injuries happening to other staff members. Let's look at correction, corrective, and preventive actions for the identified root cause. Correction action is to treat the staff member, report the injury, and assign replacement staff. Corrective actions include 1. Adding scalpel blade removal devices designed specifically for this purpose as part of procedure packs or equipment setup checklist to ensure standardized usage. Providing training for the staff on the correct usage of new scalpel blade removers. And lastly, to examine procurement processes around scalpel blade removal devices. Possible preventative actions to address this root cause include review or journey mapping usage of other sharps devices and implementing a similar safety program that includes safety devices, training, changes to existing SOPs or new SOPs, providing training for the staff on the correct usage of new devices, and to review procurement processes. Some examples of effectiveness audits include absence of similar sharps injuries or trend analysis with minimum acceptance criteria, spot audits to ensure the updated or new processes in place are being adhered to, review participation of staff in training programs, and lastly, comparing purchase data of sharps devices to the purchases of related safety devices. In the last section, we looked at how patient safety and staff safety can be improved by thoroughly examining an incident after it has occurred to determine the actual cause or causes, developing strategies to prevent a reoccurrence of this incident, and using CAPA to ensure the solutions are implemented. Now we will look at how prospective analysis can also be used to improve patient safety and staff safety. The tools include hazard risk analysis to determine what hazards are present and what harm they could cause, and then the hierarchy of controls framework to implement the strategies to prevent these predicted hazards. To conduct a hazard risk analysis, firstly identify the hazard. A hazard is something that can cause harm to someone. Then use the risk matrix to find out the level of risk the hazard poses. You determine the risk level based on 1. The likelihood of that hazard causing harm, and 2. How severe the impact would be should the hazard cause harm. Most facilities will have a procedure for exactly how the likelihood and impact can be calculated. Once the hazard's risk level is identified, the hierarchy of controls can be used to effectively implement strategies to prevent the hazard causing adverse events. The higher the risk category for the hazard is, the more important control measures are. The hierarchy of controls is divided into 5 levels and provides you with a structured and simple way to manage hazards to patients and staff. Elimination is the removal of the hazard. This is obviously the best way to prevent a bad outcome. Substitution is the replacement of the hazard with a safer alternative. Engineering controls are designed to further protect people from hazards by creating a change to the worker's environment. Administrative controls ensure that the staff change the way they work and that implementation of the control measures is successful. Personal protective equipment is the last line of defense and considered the least effective control measure. To illustrate how prospective analysis can be utilized in clinical practice, we will look at case studies now, one pertaining to patient safety and one to staff safety. We will now review how the hierarchy of controls can be applied to a patient safety hazard, malignant hyperthermia, and a staff safety hazard, bloodborne infections from sharp injuries. For malignant hyperthermia, the first level of control, which is elimination, include potentially eliminating the use of triggering inhalation anesthetics and depolarizing muscle relaxants in susceptible patients with a history or a family history of MH. Substitution include using alternatives such as nitrous oxide. Engineering controls include the use of activated charcoal filters in the anesthetic machine to absorb volatile agents. Administrative controls include activities such as having a fully stocked MH card for every procedure, simulated training for all perioperative staff, and procedures in place for taking patients' history. Similarly, for the staff safety case study, elimination control for bloodborne infections from sharps injuries include elimination of unnecessary sharps and injections. Substitutions can further reduce sharps injuries. Examples include introduction of needle-free intravenous systems and use of blunt-tip suture needles. However, in many cases, elimination or substitution of a sharp is not physically possible. In these cases, we need to look at engineering controls, such as the use of safety engineered devices that are specifically designed with a safety feature like scalpel blade removers and retractable syringes. The next step is administrative controls. Examples of administrative controls include having an exposure control plan, standardizing compliance with safe work practices, and ensuring staff are adequately trained in safe work practices. PPE is the last level of control, and some examples of this level of control for bloodborne infections include double gloving and protective footwear. I would like to end today's session with a review of common errors that can occur during retrospective and prospective analysis. For retrospective analysis, common errors include 1. Ending analysis at a symptomatic stage. 2. Assigning root causes of the problem as the Y event that preceded the actual root cause. 3. Looking for a single cause. 4. Identifying only correction actions rather than corrective actions and preventive actions. And finally, not conducting an effectiveness audit. Using prospective analysis tools can improve safety across the board. However, they must be used correctly to be effective. The following errors are relatively common and include 1. Not actually conducting the prospective analysis in the first place. 2. Not identifying all hazards. For example, the all too common practice of simply ignoring staff safety issues. 3. Implementation being conducted ad hoc. 4. Relying on administrative and PPE controls at the expense of higher levels of controls. And last but not least, not conducting an effectiveness audit. I hope today's session will prompt you to look at adverse events and potential hazards differently and see them as real opportunities to improve healthcare systems, remembering that you now have structured tools to address adverse events and potential hazards in a systems-based approach. I would like to thank you for your participation and to thank Maureen Monteith and Dr. Michael Sinnott, who contributed immensely to this presentation.